All right, welcome back to the deep dive. Today we're doing a hardcore pharmacology prep session.
Ooh, rapid fire.
Yeah, all killer, no filler. Perfect for you orthopedic residents out there gearing up for your big exams.
FRCS, you name it.
Exactly. And for this deep dive, we're tapping into some awesome notes called Ortho Made Simple
Nice.
from the website mokyingren.sg. These notes are like pure gold.
They are.
Put together by Dr. Mokyingren, top-notch sports surgeon from National University Hospital in Singapore.
Yep, and he smashed his FRCS just last year.
So we're talking straight from the source. Pain management, nerve pain, CRPS, anesthesia, blood replacement.
The works.
Ready to dive in.
Absolutely, let's do it.
Okay, so pain management. First up, analgesics.
The bread and butter.
Right, paracetamol. We all know it. We all use it.
First line for a reason.
But there's that ceiling effect.
Yeah. Great for mild to moderate pain, but
You hit that ceiling and
doesn't matter how much you give, no more relief.
time to step up to the big leagues, NSAIDs.
Yeah.
Okay, so moderate to severe pain, especially if it's that inflammatory kind of pain, NSAIDs are our go-to. But got to be mindful of those KIO-X enzymes.
Oh yeah, KIO-X1, KIO-X2, always important.
So when would we choose a KIO-X2 inhibitor like celecoxib over a traditional NSAID?
Good question. Well, if we want to minimize those pesky GI side effects,
The ones that come with the KIO-X1 hitters.
Right, exactly. So think elderly patients,
Or folks with a history of ulcers.
peptic ulcers, gastritis, that sort of thing. KIO-X2 inhibitor might be a safer bet in those cases.
And what about kidney function? NSAIDs can be a bit rough on the kidneys.
They can. KIO-X2 inhibitors are actually easier on the kidneys.
So really a risk-benefit analysis for each patient.
Always.
Okay, let's talk tramadol. Where does that fit in?
Tramadol, that's an interesting one. Kind of a dual action kind of guy.
How so?
Well, it acts as a weak opioid, so it binds to those Mo receptors.
Like the other opioids.
Right. But it also messes with serotonin and norepinephrine reuptake.
Interesting. So hitting pain from multiple angles.
Exactly. Makes it a good option for, say, moderate to severe pain when maybe NSAIDs aren't a good fit.
Makes sense. All right, let's talk about the big guns for nerve pain. Gabapentin and pregabalin.
Gabapentinoids, they're everywhere these days.
For good reason. They work wonders for neuropathic pain,
Pain coming from the nerves themselves.
not just tissue damage. So how do these gabapentinoids actually work?
They bind to this specific subunit on voltage-gated calcium channels.
In the central nervous system.
Yep, right in the brain and spinal cord. And by binding there, they reduce the release of those excitatory neurotransmitters.
The ones involved in pain transmission.
Glutamate, substance P, those guys.
So basically calming down those overexcited nerves.
Exact.
Nifty. Okay, before we move on, quick chat about lower limb blocks.
Essential for us orthopods.
The femoral nerve block, it's a classic,
Tried and true.
but can lead to quadriceps weakness.
Not ideal for post-op recovery.
What about the adductor canal block? What are its advantages?
The adductor canal block, it's a bit more targeted.
Also,
Well, it gets the saphenous nerve.
provides sensation to the medial leg and foot.
Right. And it also gets the nerve to vastus medialis,
But crucially, it leaves the main femoral nerve alone.
the one that controls the quadriceps.
So patients can get moving sooner after surgery.
Exactly. Less pain, faster recovery. It's a win-win.
Makes sense. All right, let's shift gears to nerve pain and a real doozy, CRPS.
Oh, yeah. CRPS.
A tough one.
First things first, how is neuropathic pain different from nociceptive pain?
Well, nociceptive pain, that's your classic pain from tissue damage.
Like a fracture, sprain, that sort of thing.
Exactly. Neuropathic pain, that's different. It's pain from damage or dysfunction within the nerves themselves.
So even without direct tissue injury.
Right. Think of it like faulty wiring.
Interesting. And this can manifest in all sorts of ways.
Oh yeah, all sorts. Spinal stenosis,
Where the spinal cord gets compressed.
radiculopathy, pinched nerves in the spine.
Even phantom limb pain.
Pain in a limb that's not even there anymore. Wow. So the pain is very real, even if there's no obvious tissue damage.
Absolutely.
So how do we treat nerve pain? Is it similar to managing nociceptive pain?
Well, simple analgesics like paracetamol or NSAIDs, they might help a bit.
But often not enough.
Right. We often need to bring in the big guns.
The medications that modulate nerve signaling directly.
Exactly. Tricyclic antidepressants like amitriptyline can be really helpful.
And those anticonvulsants we talked about, gabapentin and pregabalin.
Those two. Really targeting those specific nerve pathways.
And sometimes referral to a pain specialist is the best course of action.
Absolutely. For complex cases, a multidisciplinary approach is key.
Okay, let's zoom in on CRPS. What actually defines this condition?
CRPS, well, it's more of a syndrome, really.
A cluster of symptoms rather than one specific diagnostic test,
Exactly. And the symptoms, they can be all over the place.
making diagnosis tricky.
Very tricky. But think PSAO.
PSAQ, often with allodynia, where even light touch is painful.
Right. Then swelling, stiffness, autonomic disturbances.
Like changes in skin color or temperature.
And finally, osteopenia.
Bone loss from disuse.
So, PSAO, remember that, and you're halfway there.
PSSAO.
Wow.
Got it. And there are different types of CRPS too, right?
You got it. Type 1, that's after an injury or surgery, but there's no confirmed nerve damage.
And type 2.
That's where there's a clear nerve injury involved.
Interesting. And we use the Budapest criteria to diagnose it.
Right, focusing on those symptom clusters rather than any single test.
Can you give us some examples of how those criteria play out in each category?
Sure. For sensory symptoms, you've got allodynia, which we talked about,
Excruciating pain from light touch,
and hyperalgesia.
where pain is amplified.
Right. Then for vasomotor symptoms, you might see temperature asymmetry.
The affected limb being colder or warmer than the other.
Exactly. Pseudomotor symptoms involve sweating.
Excessive sweating or dryness in the affected limb.
And then motor symptoms can range from weakness and tremor to muscle atrophy.
Even contractures.
CRPS can really affect the whole limb.
So multifaceted presentation. And to add to the complexity, it often progresses through stages.
Yeah, it does. Early on, the limb might be warm, red, swollen.
Intense burning pain.
As it progresses, it can become cold, pale, stiff.
Muscle wasting. Joint contractures.
In the late stages, the skin gets thin and shiny, and you start to see osteoporosis.
From disuse. So early diagnosis and management are critical.
Absolutely. You want to prevent those long-term consequences.
What are our best weapons against CRPS? How can we prevent it in the first place?
Prevention is key. And vitamin C supplementation, that's a game changer.
Early.
Studies show that a daily dose of 500 milligrams for 50 days
Starting before surgery.
can significantly reduce the risk of developing CRPS.
Wow, so vitamin C is a true superhero.
It is. We think it works by protecting those nerves from damage.
Interesting. Are there any other preventative measures we can take, especially during surgery or casting?
Absolutely. Minimizing that initial noxious stimulus is key.
So avoiding tight casts.
And being super gentle during surgery.
No excessive traction or manipulation.
Exactly. Minimize trauma, minimize the risk.
It's all about being mindful. And what about managing CRPS once it's diagnosed?
Early intervention is crucial. First, we educate and reassure the patient.
Because anxiety can actually worsen symptoms.
It can. Then physiotherapy is essential.
Maintaining mobility, preventing stiffness and contractures.
And of course, we've got our pharmacologic options.
What kind of medications are we talking about?
We might start with NSAIDs for pain and inflammation.
And tricyclic antidepressants like amitriptyline can help with pain relief too.
Right. And for the bone loss, we might use bisphosphonates like alendronate,
And in some cases, sympathetic nerve blocks can provide significant relief.
performed by pain specialists, of course.
So a multidisciplinary approach as always.
Absolutely. Early diagnosis, aggressive management, that's the key to good outcomes with CRPS.
Couldn't agree more. This has been a fantastic deep dive into pain management and nerve pain, all thanks to those Ortho-Made Simple notes on mokyingren.sg.
Welcome back to our deep dive.
Picking up right where we left off, still mining those Ortho-Made Simple notes from mokyingren.sg.
Full of gems.
We were just talking about CRPS.
CRPS.
Real pain in the neck. Literally sometimes.
It can be such a complex condition.
All right, let's switch gears now. Anesthesia.
The backbone of our practice.
Let's start with local anesthetics. Lidocaine, we use it all the time.
Workhorse.
But lidocaine toxicity, that's a real concern.
Definitely something to be aware of.
What factors make a patient more susceptible to that?
Well, age is a big one.
Elderly patients, they often have.
Reduced liver and kidney function.
So their body's not as efficient at clearing the lidocaine.
Exactly.
What about other medical conditions?
Oh, yeah. Heart disease, liver disease, kidney disease, all those can increase the risk.
Makes sense. Those organs are involved in processing medications.
There are.
And of course, the dose and concentration of lidocaine matter too.
Absolutely. Higher doses, higher concentrations, higher risk.
Especially if we accidentally inject it into a blood vessel.
Which is why we always aspirate before injecting.
Make sure we're not in the vessel.
Always. Always aspirate.
And the rate of injection matters too, right?
It does. Slow and steady wins the race.
Avoid that sudden surge of lidocaine into the bloodstream.
Exactly.
Okay, let's talk Beer's block, a specific type of regional anesthesia.
Great for short procedures on the extremities.
Less than an hour, typically,
Right. You inject lidocaine into a vein in the arm or leg
after applying a tourniquet.
to create a bloodless field.
So the lidocaine can really bathe those nerves.
Works like a charm.
But Beer's blocks, they have a higher risk of lidocaine toxicity,
They do. Because, well, you're injecting directly into the venous system.
even though it's controlled.
But if that tourniquet isn't applied right or it's released too early,
That lidocaine can flood the system.
and that's when you get into trouble.
So meticulous technique is essential,
Absolutely crucial. Make sure that tourniquet is perfect.
and release it slowly and gradually.
Controlled release is key.
So what are the warning signs of lidocaine toxicity? What should we be looking for?
Early on, it can be subtle. Metallic taste in the mouth, ringing in the ears.
Feeling lightheaded,
But as it progresses, you can see seizures, cardiac arrhythmias.
even respiratory arrest.
They can escalate quickly.
So we need to be on high alert, ready to act fast.
Absolutely. If you suspect toxicity, stop the procedure immediately. Call for help.
Support the airway, breathing, circulation.
And in severe cases, lipid emulsion therapy can be a lifesaver.
Okay, moving on from local to general anesthesia. Let's talk about the inhalational agents.
Isoflurane, sevoflurane, desflurane.
They all put the patient to sleep.
They do, but they have different personalities.
How so?
Well, sevoflurane, for example, it's great for induction.
Especially in kids.
Rapid onset, pleasant smell.
So it's all about patient comfort.
Exactly. Isoflurane, on the other hand, it's a bit more potent.
Good muscle relaxation.
So better for longer procedures.
And desflurane.
Desflurane is fast-acting, but it has this pungent odor.
Not so pleasant.
Not for everyone. Often used for maintenance in adults, though.
So each agent has its own niche.
They do.
Okay, what about intravenous induction agents? When do we use those?
Intravenous agents like propofol or etomidate, we use those when we need to induce anesthesia quickly.
Emergencies, for example.
Right. Propofol is popular, rapid onset, short duration of action.
Quick on, quick
It
on.
makes for smoother recoveries.
Nice. And what about ketamine? It's got a bit of a reputation.
It does, but it's a very useful anesthetic.
How so?
Well, it's got both analgesic and amnestic properties.
Interesting.
Often used for short procedures, especially in patients who are hemodynamically unstable.
Because it tends to maintain blood pressure and heart rate.
It does. Also helpful for procedural sedation.
In the ED or ICU.
Very versatile drug.
All right, let's talk muscle relaxation. Essential for many orthopedic procedures.
Absolutely.
We've got two main types of muscle relaxants, depolarizing and non-depolarizing.
Two different ways of achieving the same goal.
Can you break down how they work and when we choose one over the other?
Sure. Depolarizing muscle relaxants, like succinylcholine.
That's the classic one.
It mimics acetylcholine.
The neurotransmitter that triggers muscle contraction.
Right. It binds to those acetylcholine receptors at the neuromuscular junction,
Causing a prolonged depolarization.
which leads to those muscle fasciculations you see,
The little twitches.
and then paralysis.
So it's like overloading the system with acetylcholine.
Exactly.
Non-depolarizing muscle relaxants, they work differently.
They do. They compete with acetylcholine for those receptor sites,
So they block acetylcholine from binding.
preventing muscle contraction.
Like a game of musical chairs, acetylcholine can't find a seat.
Love that analogy.
And some common non-depolarizing agents are,
Etracurium, rocuronium, vecuronium,
and we choose between these two types based on,
the specific needs of the case.
so depolarizing agents like succinylcholine, they're rapid onset, short duration.
Great for intubation or short surgeries.
Non-depolarizing agents, slower onset, but longer duration.
Better for those longer cases where you need sustained muscle relaxation.
And then after surgery, we need to reverse the effects of these muscle relaxants.
So our patients can wake up breathing comfortably.
For non-depolarizing agents, we use,
Neostigmine or Sugammadex.
they either inhibit the breakdown of acetylcholine or directly inactivate the muscle relaxant.
Right. Succinylcholine, that just relies on the body's own metabolism to wear off.
All right, let's move on to blood management.
Another crucial aspect of orthopedics.
So many blood products to choose from.
It's a whole buffet.
Let's focus on two: packed red blood cells and fresh frozen plasma.
The dynamic duo.
PRBCs, those are all about
Increasing oxygen carrying capacity.
replenishing blood volume after significant loss.
Basically giving the patient more red blood cells.
And FFP.
Fresh frozen plasma, that's our clotting factor cocktail.
It's got all the coagulation factors,
But no red blood cells or platelets.
so we use it to correct coagulopathy.
When the patient's clotting system isn't working properly.
Like in liver disease, massive transfusion, DIC.
Right. Gives the clotting cascade a boost.
So how do we decide which blood product to use?
It depends on the patient's specific needs.
Bleeding with low hemoglobin.
PRBCs.
Bleeding with abnormal coagulation tests. FFP.
It's all about matching the right product to the problem.
Spot on.
This has been a great overview of anesthesia and blood management.
Just a taste of what's in those Ortho Made Simple notes on mokyingren.sg. Welcome back to The Deep Dive. We're wrapping up our pharmacology cram session with those awesome Ortho Made Simple notes from mokyingren.sg.
Always a good resource.
We've covered pain, anesthesia, blood products. Now the grand finale, the coagulation cascade.
Yes, the cascade.
It's like this intricate dance of protein
A delicate balance.
to form a clot, but not too much clotting.
Exactly. You need that sweet spot.
Otherwise, you get bleeding problems or clots where you don't want them.
Exactly.
So let's break it down. Intrinsic and extrinsic pathways.
Two roads leading to the same destination.
What triggers each pathway,
Yeah.
and who are the key players?
Well, the intrinsic pathway, that gets activated when blood touches a negatively charged surface.
Like collagen in a damaged vessel.
Right. Like the body's saying, hey, there's a leak here.
Sounds the alarm.
And the key players in this pathway, you've got factor 12, X key, IX, and 8.
Roman numerals. Gotta love them.
They all work together to activate factor X,
Factor X, that's the big one.
the central hub of the cascade.
Okay, and the extrinsic pathway, what sets that off?
Tissue factor,
A protein released from damaged tissues.
but like from a cut or bruise.
So it's like a distress signal from outside the blood vessels.
Exactly. Tissue factor teams up with factor 7, and together they activate, you guessed it, factor X,
So both paths converge at factor X.
the conductor of the coagulation orchestra.
Nice analogy. So factor X is activated. What happens next?
Factor X, along with factor V, they convert prothrombin to thrombin.
Thrombin, the clot master, turns fibrinogen into fibrin.
Those sticky threads that form the clot.
And of course, there are checks and balances to prevent runaway clotting.
Oh yeah, gotta keep things in control.
Antithrombin, protein C, protein S.
With the regulators, making sure things don't get too crazy.
All right, let's talk DVT prophylaxis. Virchow's triad, stasis, hypercoagulability, and endothelial injury.
The trifecta of clot formation.
So how do we apply this to prevent DVT in our patients, especially after surgery?
Virchow's triad, it's like our DVT prevention checklist.
We got to address each factor.
Stasis, that's slow blood flow, common after surgery when patients aren't moving much.
So early ambulation, compression stockings.
And of course, medications to thin the blood.
Makes sense. And hypercoagulability, that's an increased tendency to clot.
Could be inherited, could be from medications.
How do we screen for that?
Detailed medical history is key.
Family history of clots, medications they're taking.
Oral contraceptives, hormone replacement therapy, those can increase risk.
And if we suspect an inherited clotting disorder, we can do blood tests.
Exactly, get to the bottom of it.
And then endothelial injury, damage to the blood vessel lining.
From trauma, surgery, even some medical conditions.
How do we minimize that risk?
A gentle surgical technique is crucial. And sometimes we use medications like aspirin or other antiplatelet agents.
Prevent clots from forming on that injured vessel wall.
It's all about being proactive.
Multi-pronged approach, tackling each part of Virchow's triad.
Teamwork makes the dream work.
Okay, last but not least, the anticoagulants themselves.
The heavy hitters,
Warfarin, heparin, the NOACs.
each with their own pros and cons.
Give us the rundown.
Warfarin, that's the old school one, inhibits vitamin K-dependent clotting factors.
Works well, but needs monitoring, lots of drug interactions.
Not the easiest to manage.
Heparin, that enhances the activity of antithrombin, our body's natural clot buster.
Good for both prevention and treatment of DVT and PE.
And the NOACs, those are the trendy ones these days.
They directly inhibit factor ZAO or thrombin.
Getting right to the heart of the cascade.
More predictable, fewer interactions, no need for constant monitoring.
Sounds pretty good.
They are, but bleeding is always a risk with any anticoagulant.
So careful risk-benefit analysis is key.
Always.
And what if, despite our best efforts, a patient develops a DVT or PE?
To be vigilant, especially in those high-risk patients.
Recent surgery, trauma, immobility, history of clotting problems.
DVT, you might see leg pain, swelling, tenderness, warmth.
PE, that could be trickier.
Shortness of breath, chest pain, rapid heart rate, even coughing up blood.
So many different presentations.
It's about putting the pieces together.
And then imaging to confirm.
Duplex ultrasound for DVT, CT, pulmonary angiogram for PE.
Combining clinical judgment with the right tests.
That's how we make the diagnosis.
Well, that was a whirlwind tour of orthopedic pharmacology, from pain to anesthesia, blood products, DVT prophylaxis, and the coagulation cascade. We hit it all.
Thanks to those ortho-made simple notes from mokyingren.sg.
Such a valuable resource.
Oh.
To all our fellow orthopedic residents out there, keep studying, keep learning, keep asking questions.
We're all in this together.
That's a wrap for the deep dive. Until next time, keep striving for excellence.